One. Please start now. We are live.
Namaskar and good evening, everyone. I welcome you all for today's exciting webinar on clinical updates from ESCO 2023. And with immense pleasure, I would like to welcome Dr. Asim Samar, who is Senior Consultant Medical Oncology, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, for the welcome and introductory note and to set the ball rolling. The stage is all yours, sir.
Thank you, our support team and Team Horizon for managing this conference. And this is a virtual conference. So first of all, I would like to welcome all the faculties and the joinees. And the major focus of this conference is to give a brief update about the recent time, which is going, what is going into the ESCO and how it is applicable to our clinics. So this is our motto. And this is all supported by various pharma partners who gave the immense support in the terms of scientific material and the other kinds. And our speakers are also eminent, and they are actually star in the field of medical oncology. They are running their clinics very well, their hospital, their name is very big. And they will give the justice to the topics which we have given to them. And it will be a good feast where we can discuss the academics. And basically the idea was we are going to various conferences, and sometimes it finds useful, sometimes it is not. But we have chosen some very, very important topics for today's practice. So I guess it will help everybody. And at the outset, I would request to all the speakers, actually, we all know, like 2 hours is nothing to cover a topic, no matter it is how much it is a trivial topic. So we will give our information in very brief in the limited time slots we have allotted to you. And there is nothing like we want to harm anyone's ego. But it's just to be limited with the time so that we can justice the topic and the fellow speakers also. So it is my humble request to everyone, please be aligned with the time. And I guess we will be having informative sessions all over. So we'll start with our first speaker. So, and today's all the topics will be about the prostate cancer. So first is the very well and renowned speaker from the Delhi, Dr. Sandeep Batra, and he will be speaking on the role of the apalutamide in prostate cancer. And this is the very recent and burning hot topic, how you can use this drug apalutamide, which has recently available in the Indian market, and it is in the sort of generic drug, and it has changed our day-to-day life practice also. So we would like to start with Dr. Sandeep Batra. I guess he is here and he will start. We are running actually. Hi, Dr. Sandeep.
Hi, Dr. Singh.
Yeah, it's kind of, sir, good to see you. After Lucknow, we are meeting here.
Yes, Dr. Singh.
Yes. So we are starting actually before time because we want to include some questions also if there are any. And you see some branding is there. So they will run slowly there. And so it's all stage is yours, sir, Dr. Sandeep Batra. Please start.
Sure. Thank you. So the standard question, I hope my screen is visible and I am clearly audible to everyone.
Yes.
Yes, sir.
Okay. So the topic is the role of apalutamide, and Dr. Asim said, let me before that thank you, Dr. Asim and the Team Horizon for arranging this meeting and inviting me for this session. So my role is to discuss about the newer introduced drug in Indian market, apalutamide in prostate cancer. So there are basically 2 settings where it is approved, although this drug was approved since 2017-18 in US and was FDA approved for 1 setting and then subsequent in 2nd setting. It has recently entered the Indian market and it has very rapidly ascended to the same level at which level abiraterone, enzalutamide, and other hormone therapies are. So without much ado, let's start with some basic points. Just let me, okay. So first global approval for this drug in non-metastatic castration-resistant prostate cancer was in February 2018. And subsequently, it was also approved in September 2019 for management of metastatic castration-sensitive prostate cancer along with the ADT. A little bit about the mode of action. Apalutamide is an androgen receptor inhibitor, which is almost similar in action to the other androgen receptor inhibitors, and the close rival is enzalutamide. It binds directly to the and ligand binding domain of the androgen receptor. This androgen receptor binding of the drug leads to nuclear translocation, which further inhibits the DNA bindings and thus leading to impediment of the AR-mediated transcription. So this leads to decreased tumor cell proliferation, increased apoptosis, which leads to decrease in the tumor volume in xenograft as well as the actual human models. Just to define what is non-metastatic CRPC, which is a newer introduced term whose need was felt when patient were failing at the loco-regional site despite having been treated with a surgery or radiation or a combination, and those who had also been exposed to a hormone therapy in the past, making them orchidectomy level, that is castration level, testosterone levels, and then still having the disease recurrence at a localized place. So rising PSA while on hormone therapy with a serum testosterone level below 15 nanogram per deciliter, which is the standard term for the orchidectomy levels, with no evidence of detectable disease, but only at the local site, or no evidence of disease, only a rising PSA. It is called non-metastatic or M0 CRPC. Now, whenever there is a PSA increase without any visible evidence of disease, there has been correlation that if the PSA doubling time, which is the time taken by PSA to double in its if it is less than 3 months, then within 9 months, the metastasis develop in a patient who only had a rising PSA. In contrast, those patients who had a PSA doubling time more than 15 minutes take about 50 months for the metastasis to develop. And this concept led to finding the new drugs and mechanism to decrease this development of metastasis. And a new marker was introduced as far as survival outcome was come, and that was metastasis-free survival. That is, in a non-metastatic CRPC patient in which the PSA is rising, any modality or intervention that leads to delay in the development of metastasis, that term was labeled as metastasis-free survival. And understandably, since it is a hormone therapy, the cutoff of in the trial was PSA doubling time should be more than 10 months, and then they were improved. We will be coming to the details of that. Now, these are the the same thing that I have discussed in the first trial. So the Spartan trial was for the non-metastatic castration-resistant prostate cancer. It was a multi-center randomized double-blind placebo-controlled, very well done phase 3 trial. Almost 1,200 patients were enrolled, and key inclusion criteria was non-metastatic CRPC and PSA doubling time less than equal to 10 months. That means those patients who are more likely to develop metastasis in their next 3 to 5 years of life. Key exclusion criteria was metastatic disease. That's understandable. We are discussing about NMCRPC. So the active arm was apalutamide 240 milligram once daily, along with the standard of care, that is ADT, versus placebo plus standard of care, which was ADT. And the primary endpoint was metastasis-free survival, and selected secondary endpoints were time to metastasis, progression-free survival, time to symptomatic progression, overall survival, time to initiation of cytotoxic chemotherapy, and patient-related outcomes. As is the cases, the usually well-matched patient characteristics. These were just the gist of both the groups. Median age of 74 years, in which age this tumor is more common. Median time from initial diagnosis, about 8 years. Almost similar number of patients with surgery or radiotherapy in both arms. Similar exposure to the hormone therapy. Similar levels of PSA and Gleason score was also comparable versus local or regional disease, there 60%. So what was the primary outcome? So if we see the chart, there were 2 additional years that the patient got with only one tablet of one strength of 240 milligram once a day taken continuously, and that deferred the development of metastasis by a whopping 24.3 months, vis-a-vis only ADT as a standard of care. So it was a 2:1 design. So you can see 806 patient in the active arm versus 401 in the placebo arm. And there was a huge gap between the two arms in the Kaplan-Meier curve, with 40.5 months being the median metastasis-free survival time in the active group versus 16.2 months in the placebo group. And there was 72% reduction in distance metastasis or death secondary to the use of the apalutamide in the MCRPC setting. So primary endpoint was well met, and there were consistent results in all the major subgroups, whether the PSA doubling time, although it was less than equal to 10 months where the patients were enrolled, but they were further subgrouped into less than equal to 6 months or more than 6 months. Both the subgroups equally benefited, whether there was a prior use of any bone sparing agent or not, because there are some trials which say use of zoldronate or denosumab. These drugs, they decrease the development of the metastasis. So irrespective of the bone sparing agents, both the groups were submitted equally. And whether the locoregional disease in the form of lymph nodes are present at the baseline or not. Now, coming to the secondary endpoints, having achieved the primary endpoint of metastasis-free survival, coming to the secondary endpoints. Okay, so before we go to the secondary endpoints, what were the sites of metastasis that developed? They were also the same whether the patient received placebo plus ADT or apalutamide plus ADT, bone being most common, nodal being the second most common, and visceral being almost similar in both the subgroups. So this was not changing the biology of the tumor by increasing metastasis at one site and decreases metastasis at one site. They were just with the natural history, with or without the introduction of the apalutamide. The sites of metastasis were as per the normal disease biology, they were not changed. Now, secondary outcome was also supported by the primary outcome was also supported by the secondary endpoint of time to symptomatic progression, whether it was spinal cord compression, need for surgical intervention, or the need for radiation therapy. They were also better in the active arm with the apalutamide versus the passive arm, which is only ADT. So time to symptomatic progression, if you see, the p-value is significant, less than 0.001, and there is a 55% reduction of the skeletal-related events in the apalutamide arm versus the placebo arm. Sorry for these tongue twisters. Time to initiation of cytotoxic chemotherapy was also almost 56% risk reduction with the use of apalutamide. Overall survival, which becomes an important point, but since prostate cancer patients have a long survival thanks to so much of newer developments and therapies available, it was a secondary endpoint, and it was also proven that there is a 30% risk of reduction of death, leading to an improved overall survival. So to summarize the secondary endpoints, median time to metastasis, apalutamide versus placebo 40.5 versus 16.6 months, median progression-free survival, almost similar difference. Median time to symptomatic progression not recorded in both the group, median overall survival not recorded versus placebo 39 months, and median time to cytotoxic chemotherapy was almost similar, although we have shown the hazard ratio was more in favor of cytotoxic chemotherapy, as well as overall survival, as well as symptomatic progression. So all the secondary endpoints were favored with the use of the apalutamide. Now, there is a talk these days about secondary progression-free survival, and apalutamide, thankfully, also as an exploratory endpoint, showed a 51% reduction in the second progression, whether it was PSA rise or radiographic or symptomatic or any other combination. Time to PSA progression was also improved. PSA response, so there was a dramatic PSA response with the introduction of apalutamide. And you can see on these water flow charts that on the left side is the red water flow chart, which shows a very immediate response in the PSA as compared to the placebo. Now, no trial is complete without assessing the treatment-related quality of life and health-related quality of life issues. And thankfully, apalutamide in Spartan trial did not have any further flags as well as quality of life issues were concerned. There was no negative impact on the quality of life with this combination as compared to vis-a-vis placebo. The most notable side effects, which are typical of class effect of hormone therapy, are fatigue, which was seen in a significant higher number of patients, and we also see that in the similar molecule enzalutamide. Hypertension was comparable skin rash, slightly more with these diarrhea, slightly more nausea, slightly more weight loss was there, arthralgias were there. Fall is something that was also flagged with the enzalutamide as a CNS event, and to some extent, since it is a same class molecule, the same has been identified with this drug also. Just to mention, darolutamide has less CNS side effects as compared to both these molecules. Other adverse events in the form of fracture, dizziness, hypothyroidism, they were also slightly on the more side. But despite all these things, the health-related quality of life as reported by patient were not decreased. So to conclude the Spartan trial, there was 30% reduction in the death, meaning overall survival was better. 51% risk reduction in progression-free survival too. Patient-related outcomes were maintained, and there were consistent improvements in the secondary as well as the exploratory endpoints. So metastasis-free survival was improved by 24.3 months, which was a significant improvement. Along with this, symptomatic time to progression was also improved. And the most common adverse events were fatigue, hypertension, rash, diarrhea, nausea, which are part and parcel of the this class of drugs. Just a brief about the Titan study, which is apalutamide in patients with metastatic CSPC, castration-sensitive prostate cancer. Just the final survival analysis part, because this drug is already approved and is being used in the MCSP setting, similar to the way abiraterone and enzalutamide are being used. So interim analysis showed overall survival benefit. So final radiographic PFS and overall survival benefit, those were also proven with this drug in the Titan trial. And if you see the two curves, they are separated, and there is a significant difference of T less than 0.001 in the radiographic PFS and P of 0.005 in the overall survival curves. So final overall analysis, except for one subgroup, although there was very less number of patients enrolled in the prior docetaxel use, which was only about 12% of the total population. If you see, hazard ratio was not favoring those who were prior exposed to docetaxel. In contrast, whether it was a low volume disease or a high volume disease, the apalutamide worked for both the subgroups equally well, and there was a significant improvement in apalutamide versus placebo as far as event-free survival and median overall survival was concerned. So it improved the overall survival as well as delayed the second progression-free survival and castration resistance in a metastatic hormone-sensitive prostate cancer setting. So this Titan finally concluded that despite crossover of the active drug to the placebo part, apalutamide plus ADT improved overall survival, delayed castration resistance, maintained health-related quality of life, and it had a consistent safety profile in patients with metastatic castration-sensitive prostate cancer. So both Spartan and Titan have propelled this drug into the same league as enzalutamide and abiraterone. However, they are still not approved as a combination of hormone therapies, but as a standalone drugs. So it also yields earlier reduction in PSA versus enzalutamide in metastatic castration-sensitive prostate cancer. And this was something which was presented in the Genitourinary Cancer Symposium 2022. PSA response and then the PSA 90 response, that is at 3 months, the drop in the PSA was 70.4% with enzalutamide or apalutamide versus the other drug. So just a brief of the indication and usage. We only know the indications. It is a non-metastatic castration prostate cancer and it is a metastatic hormone-sensitive prostate cancer. Recommended dose is 240 milligram once daily. And the main warnings similar to the enzalutamide and falls and fractures and seizures, and those patients who have a prior history of seizure or CNS disease, we should be cautious of using this drug because of the class effect. So with this, I think I will be bang on time, finishing just in time, rather 15 seconds earlier, and I hand it over back to Dr. Asim with thanks and back to the organizers. Thanks for your patient listening. Dr. Asim, you are muted.
Yeah, thank you, Dr. Sandeep Batra sir. So you have presented the Titan study very nicely, and I'm sure we are using this drug in and out nowadays.
So apalutamide, I have started using it off late over the last 2 months. It has been recently available in the market. I have not seen any challenge as far as the side effects are concerned. And the PSA response, I do agree that it is rapid as compared to what I have seen with the abiraterone or with the docetaxel. Enzalutamide, there is a mixed bag. Some patients do get too much of weakness with it, so I had to discontinue. I have not faced this challenge with the apalutamide till date.
So do you find it is safe in the elderly population also?
Yes. So rather, the patients, luckily, no one had a prior CNS history, but there has been no flags that have been raised by the elderly patients.
Okay. Thank you, sir. So
Thank you,
now I would invite our next speaker. So our next speaker, I guess Dr. Tanmay Mandal has not joined, Gitika.
Yes, sir.
Yes or no? He's not joined.
Okay, so can we ask Dr. Rohit Rebella to present his talk? Gitika, did you connect it with him?
Yes, sure, sir.
So Dr. Rebello is there in the meeting.
Dr. Rohit is there?
So yeah, Dr. Rebello is there. Dr. Rohit is there. So can you call once? Vishal, can you call once?
You want me to do it now?
Yeah, Rohit sir is available, ma'am.
Okay, fine.
Yeah,
Let me just share. Hi, sir.
Yeah, hi, Dr. Rohit. So I welcome you. Actually, your turn has come one line prior.
Yes.
And Dr. Tanmay Mandal has some technical problem with joining. So I invite you to present the study of PROPEL, final OS analysis of olaparib and abiraterone versus abiraterone and placebo in first line MCRPC. So Dr. Rohit is in Udaipur, which GBH, I guess?
Yes, sir, GBH.
GBH, yeah. So earlier he was in Ananta Medical College and he got the good name and fame. But now he has moved to other eminent hospital in the Udaipur, the GBH American Hospital. So he will be speaking on the topic PROPEL study. And yeah, you can start, Rohit.
Yes, I'll share my screen. Okay, am I, is the other slides visible and am I audible?
Yes, sir.
Yeah. Okay.
Yes, sir.
Okay. Good evening, everybody. At first, I would like to thank the organizers for inviting me to give this presentation. So I will be presenting the PROPEL study, which is basically the final OS analysis of olaparib and abiraterone versus abiraterone and placebo in first-line metastatic castration-resistant prostate cancer. So the final OS result of this was presented recently. It is a clinical trial which compares the efficacy of olaparib and abiraterone versus abiraterone placebo in first-line metastatic castration-resistant prostate cancer. It examines the impact of overall survival and other key outcomes in this particular patient population. So it's a randomized, double-blinded phase 3 study which enrolled patients in the first line, regardless of the HRR gene alteration in metastatic CRPC patients. Patients were randomized to either olaparib and abiraterone or abiraterone and placebo. Double-blind, placebo-controlled, random assignment, abiraterone 1000 mg once daily in combination with either olaparib 300 milligram twice daily or a placebo. And all patients received prednisolone 5 milligram twice a day. As per the abiraterone label requirement, random assignment was stratified by distant metastasis type, that is bone versus visceral. So the primary endpoint was IB, investigator-associated progression-free survival or death from any cause in the absence of disease progression. So the primary analysis of PROPEL trial, which was presented in 2022 ASCO showed a significant 34% reduction in risk of disease progression or death. The study aimed to assess whether olaparib in combination with abiraterone improved OS compared to abiraterone and placebo. So RPFS is the time from randomization to radiographic progression or death from any cause. The study also evaluated safety and tolerability of the different treatment regimens. A key secondary endpoint was OS in the study, and other secondary endpoints included time to first subsequent therapy, PFS2, health-related quality of life, and the FACT-P questionnaire also was assessed to look at the functional assessment. So When you look at overall survival, the combination of olaparib and abiraterone demonstrated a statistically significant improvement in OS compared to abiraterone and placebo. The median OS was significantly prolonged. The hazard ratio favored olaparib, indicating a reduced risk of death. In patients with BRCA positive, the median overall survival was not reached in the olaparib containing arm versus 23 months in the placebo abiraterone arm. In BRCA negative group, the median overall survival was almost similar. So at the final data cutoff for OS, the median OS was 42.1 months in the abiraterone olaparib versus 34 months in the abiraterone placebo group, which was a 19% reduction in death. Mutational status is known to be important, and several trials have shown improvement, mainly in these patients with BRCA2 especially, to a lesser extent with HRR and with HRR mutations. And when you look at the radiographic progression-free survival, the combination showed a significant improvement in radiographic progression-free survival. The median RPFS was significantly prolonged. And this particular panel just shows the probability of progression-free survival and how beautifully the graphs are separating when abiraterone plus olaparib is given as compared to abiraterone plus placebo. So definitely a significant benefit. The median being 13.9 months versus not reached in case of the olaparib. So interim analysis, it met its primary objective, showing us significant improvement in RPFS. The primary endpoint of RPFS and multiple secondary endpoints were also met. The overall survival, as usual, was found to be significantly better in patients with the BRCA mutation, and the OS in the non-BRCA mutated patients was not that significantly better. And this, as we'll go through some other studies also, I think it's kind of similar in most of the other studies that are trying to evaluate the use of these PARP inhibitors in first line. So as I mentioned before, the time to pain progression, as PFS we have discussed, so the time to pain progression also, patients with olaparib group, they experienced a longer duration until worsening of pain, and the hazards ratio favored the olaparib group, indicating a reduced risk of pain progression. So the safety profile of olaparib with abiraterone was consistent with previous studies. Main issues were, as seen, were anemia, fatigue, nausea, back pain, and diarrhea. 2 patients did develop MDS, and both arms had a similar incidence of new primary cancers and pneumonitis. The incidence of serious adverse effects was similar between both the groups. So in conclusion, in first-line metastatic CRPC, the combination of olaparib and abiraterone demonstrated a significant improvement in OS, radiographic progression-free survival, and time to pain progression. This findings support the use of olaparib in combination with abiraterone as a potential treatment option for patients in metastatic castrate-resistant prostate cancer. Further research is needed to explore the impact of HRR gene alterations on treatment response. The HRR mutated cases are more effectively treated, but there is a big time. There is still a big effect in non-HRR mutated cases, as said by Dr. Clark, who analyzed this study in detail. And the important thing to recognize is, when you're trying to, examine this subgroup of these populations, you'll find that there is definitely a benefit when you look at the two groups, right? In the population that had BRCA, and the benefit was not as significant in the population that did not have BRCA. So if you look at the study that used niraparib also, they did find benefit more in the BRCA group as compared to the HRR group. And even the TALPRO study, which was basically using talazoparib with the enzalutamide, it resulted in a clinically meaningful and statistically significant improvement in the RPFS versus the standard of care. So there is, upcoming data in this particular field where PARP inhibitors are now moving on to the first line, and probably in future, I would suspect that in patients who have BRCA mutation, I think this is going to be the mode that we are going to follow. There's also some sort of preclinical data that says that this using anti-androgens with this BRCA inhibitor, it has some synergism that increases the BRCA-ness of the tumor. And that is one of the reasons that we are seeing these beautiful results, especially with olaparib and even to an extent with talazoparib. Thank you.
Thank you, Dr. Rohit. It was a nice talk, actually. And
So Dr. Tanmay Mondal has joined.
Okay. Let me present the keynote study and then he will speak about. So Dr. Rohit, you have presented very excellently. And as usual, you are the good orator and speaker. So what is your current practice, Rohit? Did you use the same combination or anytime have you used this?
No, sir. This sort of combination I have not started using. Actually, testing BRCA is something that we've started very recently now. It's been doing it only for the last 1 year because obviously patients are unable to afford these expensive therapies now. And the one scheme that we had where we could prescribe this has now become extremely rigid in its this thing. So that's why right now we are not practicing this. And I would like to see some more data, some more mature results, especially in OS, and then probably I would. But my thing is I'm going to use this in BRCA patients, not in non-BRCA.
Okay, unselected patient, you don't want to use it, right?
I'm not still convinced that the data is strong enough because the niraparib did not work, so I'm a little hesitant in that.
Okay, and in how many percentage of cases you are doing the HRD testing or BRCA testing in prostate cancer?
I would say less than 15%.
Less than 15.
Yeah.
Okay, and it is on archival tissue or it is on the fresh biopsy?
No, I generally do these now since it's coming onto the first line. Now I've started doing it in the first line, but earlier we used to always do it in archival tissue.
Okay, so that's nice. Thank you, Dr. Roy.
Thank you, sir.
Okay, yeah. So now, if Geetika, you can put my slides so I can present that.
Yes, sir. You can.
So you will share the slide or I will share that? Just a minute.
So can I share from your slide, sir?
Let me try to share it so that it will be easy to. Is it moving?
Yes, sir. Make it full screen, sir.
After making full scale, it will not move, I guess.
So not an issue. Can I
No,
run
it is,
from?
it is now. It is the second slide.
No, sir.
Okay, you can run the slides. Yeah, you can share from your side. So I will present this. Yeah, Geetika, can I start now?
Yes, sir.
Okay. So I will present this study, Keynote 010 study, which was recently discussed in the ESCO. It is about pembrolizumab plus olaparib versus abiraterone or enzalutamide for patient with previously treated mCRPC. It was a randomized phase 3 trial, and the study was known as a Keynote 010 study. So next slide. Geetika, next please. Okay, aim of the study. So it was, you see, there was an unmet need for effective therapies for patients with heavily pre-treated mCRPC. We all know, like, till the patient progress to the HSPC to mCRPC, there are various lines of the therapies we have used, and very less is remaining for the metastatic CRPC patients. And classically, the survival of the mCRPC patient is around 2 years. Whatever treatment you give till this date, the survival is less than 2 years. So everybody wants to improve the survival outcome. So there are various methods to various trials which try to improve this survival for this particular subset of the patient. And ultimately, every kind of the patient who has been diagnosed with a prostate cancer in metastatic setting, they usually turns to metastatic CRPC. So it was the Keynote 010 trial, which has evaluated the efficacy and safety of the pembrolizumab plus olaparib versus abiraterone or enzalutamide for molecularly unselected patient. The catch is the unselected patient, and I guess this was the major problem with this trial. Was it was unselected patient with mCRPC after a next generation hormonal agent and docetaxel. Next. So actually they have captured the patient of usual clinical practice, where key eligibility criteria was histologically or cytologically confirmed metastatic CRPC patients, progressive disease after AB or angina, but not both, and docetaxel. So suppose patient has come to you and we have given docetaxel, after that abiraterone or enzalutamide, and then progress. So it is mostly after third line. So they wanted to try with the pembro plus ora versus AB or ENJA. If they have exposed to the ENJA, then AB, or AB exposed to the ENJA, then AB, or AB vice versa. So ECG PS0 or 1 tissue samples for biomarker assessment was captured earlier, and the stratification factor was this particular trial was the prior new hormone agents treatment with the AB or ENJA or measurable disease at the baseline, yes or no. So this was a stratification factor. So it was quite a large trial, and around more than 700 patients they have included in this trial. The randomization design was 2:1. So the experimental arm has 529 patients, where the pembro standard dose was given 200 mg Q3 weekly for 35 cycles, that is 2 years, which is very standard with the cases of the lung cancer. And the olaparib, in combination with the olaparib in the standard dosing schedule of the 300 mg BD, and it was compared with the comparator arm. It was abiraterone 1000 mg OD or enzalutamide 160 mg OD. So patient has, I have explained, like if they have exposed to AB, then they will be receiving ENJA, or exposed to ENJA, then they will receive abiraterone. So what was the primary endpoints? There was dual primary endpoint. One was the radiographic progression-free survival, and other was the at the interim analysis 1 and at overall survival at the interim analysis 2. And secondary endpoints were time to first treatment start by the cytotoxic chemotherapy, and the overall response rate and safety at the interim analysis 2. Next, please. So endpoints were the dual primary endpoints were radiographic progression-free survival by blinded independent central review committee by the modified RECIST criteria 1.1. OS final testing at second interim analysis. Secondary endpoints included ORR response rate by blinded independent central review committee with the criteria with the modified RECIST 1.1, and safety and adverse event. Next, please. So there were 793 patients, close to 800 patients were randomized to pembro plus olaparib or next generation hormone agent between May 2019 to July 2021. So 2 years there was a recruitment period. Ultimately, the keynote 010 study was stopped for the futility because the experimental arm was not performing better than the control arm. And as of January 18, 2022, the median follow-up of the second interim analysis was 11.9 months. Baseline characteristics were well balanced between the two arms. Next, please, Geetika. Okay, this was the two demographic profile of the two groups. So median age was 71, and in the both the group it was 71 and 69. So it is quite similar with our clinical patients. PS score was 1. In the pembro arm it was 51.4%, and PS1 was 47% patient in the control arm. So prior NHA treatment, abiraterone only was given, have received by the 54.6% patient in the experimental arm, and 45% patient had received enzalutamide. Whereas in the almost same, like NHA group, it was 54.2 and 45.5%. So exactly the same amount of the patient have received the same type of the therapy. Prior docetaxel was received by 99.2% in the experimental arm, and it is the same in the NHA arm also. Disease measurable disease was in 46% and 45% in the control arm. So this was a Gleason scoring. I don't know how they correlated with this, but now the question is of HRR gene alteration status and BRCA mutation status. See, in 2019, that this kind of the investigations were not very prevalent in the third world countries, though it was there in the Western countries. So you see, like HRR mutated patients were 26% in the pembro plus olaparib arm, whereas in 22% in the NHA arm. Non-HRR mutation was 67.1, almost double was the patient in the olaparib plus pembro arm, and same is true with the NHA arm. So they have taken the unselected patient where the non-HRR mutated patient were just doubled with the HRR mutated patient. 6.6 or 6% or 12% patient had unknown mutation, or their status was not known. The BRCA mutation status was, you see, 9.8% patient in the Pembro plus olaparib arm were BRCA2 mutated, and 9.1% in the NHA arm. Non-BRCA mutated 83.4 and 70. That means like they have no mutation, no HRR, no BRCA. There were 83.4% of the patient. PDL1 status, you see, it was less than 1 in the 69% of the patient, and more than 1, it was 24% of the patient. Here, the similar, almost similar thing happened in the NHA arm. You see, it was 74.6% patient had less than 1 PDL1, and 18.9% patient more than 1. So you see, nowadays we know like olaparib works better in the HRR mutated or BRCA mutated. So it was almost, you can see, like 36% patient had HRR mutated or BRCA mutated, and PDL1 was 24% patient were present, will positive for the this one, PDL1 positive, where the Pembro works better. So it was almost 1/3 of the patient was the good, you can say, good biomarker positive patients. So the study was failed because the other patient, which were unselected, which were just double of the selected patient. So the results were not good. Next, please. So the primary endpoint was of radiographic PFS was 4.4 months with the Pembro plus olaparib versus 4.2 months with the next generation hormonal agent. So the hazard ratio was not significant. Actually, it was not important. It was 1.02. So whenever the hazard ratio is more than 1, it is not, the experimental arm is not behaving better. So you can see that curve also. There is extremely overlapping curve, and sometimes the experimental arm fallen below the control arm. So this was the thing. You see, the events were 291 in the experimental arm, whereas 128. So it was the 2:1 randomization. So almost it is similar, and 4.4 versus 4.2 months. So the difference was not significant. Next, please. Overall survival was also not better in the Pembro plus olaparib arm. Statistically, it was not significant. It was 15.8 months for the Pembro plus ola versus NHA, it was 14.6. So the p-value was not significant. You see the graphs are overlapping, and 2-3 times they are kissing each other. So it is not significant. Next, please. So additionally, there was no difference in time from subsequent therapy between these two groups. So you see, like if you start Pembro, olaparib or NHA, there was no difference. You need to start cytotoxic chemotherapy almost at the same period of time. So it was 7.2 versus 5.7 months. So there was very marginal difference between these two groups where the cytotoxic chemotherapy was used. So Pembro or olaparib, they can't give the much difference in the cytotoxic free chemotherapy free survival. Next, please. Yes, the most common subsequent therapy in the both arm was cabazitaxel. The oral response rate was 16.8 with pembrolizumab plus olaparib versus 5.9% with next generation hormonal agents. So the oral response rate was significantly better with this Pembro plus olaparib arm. But there was 4 complete response rates, complete response in the Pembro plus olaparib, and none in the next generation hormone agents. An exploratory analysis of subgroup by tissue-based homologous recombinant repair gene alteration at a second interim analysis suggested a potential difference between RPFS. So here comes the catch of the study, which is like you can see it was hazard ratio was 0.53. So that means if you select the population who are HRR positive or PDL1 positive, so they give the best result, and in the particular subset of the patient, the HR ratio was very impressive. It was 0.53. So they needed to select the patient upfront, and maybe it is a future direction for the other studies where they can try this combination in the particularly patient who are HRR positive, HRR positive or BRCA positive or PDL1 positive. So this is the important thing. So this is the only thing which we can gather from this study. Next, please. Adverse event, we know like olaparib also and pembro also, they incur the as compared to the NHA, they have the great amount of the side effect. So grade 3 treatment related adverse event occurred in 34.6% patient with the experimental arm, that was pembro plus ola, versus 9% only in the patient with the next generation hormone agents. 5% and 1% patient had respectively grade 3 immune mediated adverse event. The most common treatment related adverse event was this kind of anemia, nausea, fatigue, decreased appetite, asthenia. So, and diarrhea. Diarrhea comes like at the sixth position because of the olaparib, and sometimes the immune mediated diarrhea also with the pembrolizumab. You see, other side effects are very less in this NHA arm, and the hypertension is more common in the newer hormonal agent, hot flashes also. Otherwise, the other side effects are common in the experimental arm, whether because they are because of the pembro or because of the olaparib, but they were there higher in the number. Next, please. So, what was the conclusion? My conclusion for this study was, if you select the patient, then it is a you can see some radiographic progression-free survival advantage. But if you unselect the population, there will be no statistically significant RPFS. The randomized phase 3 Keynote 010 study did not show a statistically significant improvement in the RPFS or overall survival with the pembro plus olaparib versus an active comparator next generation hormone agent for men with the molecularly unselected previously treated MCRPC. So if you want to give an unselected population, might it is better to give NHA, this because it is less cost effective. Means like cost effective agents are the NHA. The study was stopped for futility after the second pre-specified interim analysis based on the guidance of the External Data Monitoring Committee. Overall response rate was higher in the pembro plus olaparib group versus the next generation hormone agent. So you see, like it was 16% versus the 4%. So it is there, and I guess if you select the population, the overall response rate might increase. The safety profile of the pembro plus olaparib was consistent with the previous reports, though there were more grade 3 treatment related adverse event occurred with the pembro plus olaparib versus next generation hormone agent. And ongoing studies are investigating other pembro plus olaparib based combination in the prostate cancer. And I guess the future direction is to try in the HRR positive or BRCA positive or PD-L1 positive patients, this combination or pembro. So I guess this is the last slide. Thank you. So thank you for your patient listening. And if you have any question, I would be happy to answer that. Gitika?
Yes, sir.
Yes, sir. Yes, sir. So Dr. Tanvi sir is there, sir.
So it is like 7:19. So but our time was to start panel discussion on the 7:20. So can we start that?
I think I can present the slides if okay.
Yeah. Dr. Tanmay, you can start that.
Okay, so Geetika can fine.
Hi Tanmay. Nice to see you on the screen.
Right. Okay, so Geetika, if possible, you can just upload the slide.
Yes, sir.
Very long Tanmay we haven't met.
Yes.
After Delhi meeting.
Because I think yes, after Delhi meeting, no further meeting has happened in such a manner. I think in lung master class I went on Friday and I came back on Saturday, I think.
Yeah. So I was not there. Dr. Tarachand was there. Me and Tarachand are working in same institute. So actually both we are not taking leaves together. So Dr. Tarachand was there.
Right.
Yeah. So I welcome Dr. Tanmay Mandal. He is from Amri Hospital, Thakuria in the Kolkata, and he's our good friend and good colleague. And we are meeting very frequently and discussing the issue. So I thought I should invite him to discuss in this forum also. So very warm-heartedly, I want to welcome Dr. Tanmay Mandal, and you please start that. Thank you.
Okay, so so good evening, everyone. Thanks, Dr. Asim, for inviting me for this talk on this hormone prostate cancer. So I will be presenting the efficacy and safety of darolutamide in combination with ADT and the docetaxel, the phase 3 RSN study which we have. Next slide, please. So phase 3 RSN study evaluated the efficacy and safety of darolutamide in combination with ADT and docetaxel. So what we know is that darolutamide is a novel androgen receptor antagonist. This study was aimed to assess the impact of this combination therapy on overall survival in patients with metastatic hormone sensitive prostate cancer. Next slide, please. So study design, it was a random, next previous slide, please. So the study was randomized. It's a randomized double-blind placebo-controlled trial. Patients were randomized, randomly assigned to either receive darolutamide or placebo in the combination with ADT and docetaxel. The primary endpoint was overall survival, and the secondary endpoint included the radiographic progression-free survival and the time to progression. So these were the things which were done in this study. Next slide, please. Next slide, please. So this study included around some 1,300 patients, 1,306 patients to be specific, in this metastatic hormone-sensitive prostate cancer. The mean age was around 50 to 55. The majority of the patients were around Eastern PS1. Next slide, please. So the combination therapy of darolutamide, ADT, and docetaxel significantly improved the overall survival compared to placebo. The median overall survival was around 43.7 months in the darolutamide group compared to around 42.4 months in the placebo group. The 4-year overall survival, what we saw, was around 62.7% in the darolutamide group compared to 50.4% in the placebo group, and it was clinically and statistically significant. So what we see that there was a significant improvement in the median overall survival and also in the overall survival at the end of 4 months. So the hazard ratio for overall survival was 0.68. That means the risk of death was reduced by around 32%. So this was the things which we saw, which was also statistically significant. Next slide, please. So the combination therapy demonstrated a significant improvement in the radiographic progression-free survival also. So the median radiographic progression-free survival was also in the range of 40 months, for 15 to 16 months in the darolutamide group compared to the placebo group, which compared to, I think, 12 months in the placebo group, and the hazard ratio for radiographic progression was also statistically significant. Next slide, please. So the patients receiving darolutamide in combination with ADT and docetaxel experienced a delayed time to pain progression. That means the median time to pain progression was around, I don't remember the exact month, but the hazard ratio of this time to pain progression was 0.79. That means there was a reduction in 21% of the time to pain progression in that group. That is what we saw in the darolutamide arm. Next slide, please. So the safety profile also was a well-tolerated regimen. It was a well-tolerated regimen. The combination was generally well-tolerated and no unexpected safety concerns were seen. The most common adverse effects were fatigue, nausea, and anemia. So what we generally think that, yes, when we are using a triplet combination with ADT plus docetaxel plus darolutamide, generally we prefer to feel that there might be an increased incidence of side effects. That is what our general perception is. But in this trial, what it was seen that there was no unexpected increase in the side effect profile, and it was a well-tolerated regime as per the trial design and the trial statistics. Next slide, please. So in conclusion, what we see that the phase 3 RSN study demonstrated that the combination of darolutamide, ADT, and docetaxel significantly improved the overall survival in patients with metastatic HSPC. The combination therapy also showed benefit in terms of radiographic progression-free survival and time to pain progression. The safety profile of this combination therapy was manageable and with no unexpected adverse events. Next slide, I think this might be the last slide. So the future implications, the positive results of phase 3 adolescents may lead to a new standard of care in the treatment of metastatic hormone-sensitive prostate cancer. Although further research is warranted to explore the potential benefits of darolutamide in other patient populations and in combination with different treatment modalities, the findings of this study highlight the importance of targeting the androgen receptor pathway in the management of prostate cancer. So next slide. Next slide, please. I think, so these are the other components. Next slide, please. So with this, I think this is regarding in short the phase 3 adolescent study. So the take-home message from this is that in metastatic hormone-sensitive prostate cancer, darolutamide is a good addition. Although we have 3 agents, enzalutamide, darolutamide, and apalutamide, and both have say a differential toxicity, differential safety profile. None of them is much better than the other than the issues with certain cost and other issues. We don't have anything which is much better than the other. But yes, of course, the study which was done in this subset, it showed that the use of docetaxel with ADT plus darolutamide had an improved overall survival, improved time to pain progression, and improved delayed delay in the skeletal related events, also delay in the next line of treatment or next chemotherapy. So all these were improved in this study, and that is what we just is with a good safety profile, maintaining the quality of life.
Okay, thank you, Dr. Tanmay Mandal, for accepting our invitation. And you were busy, and I guess you were in the travel. So still you have joined the things. And I might inform you that Dr. Tanmay, we had phase 3 trial of this darolutamide in our center in the metastatic setting. So we have completed the trial for the Indian launch of this drug. And now one more trial has registered under me, which we are trying to explore the darolutamide in the non-metastatic hormone-sensitive prostate cancer. So where it is the contemporary of the Aramis study, where the population is castration-resistant non-metastatic prostate cancer. So it is a very tough subgroup, and we are struggling with the patient, but still we are finding some eligible patient. And with the experience of few patients where I have given this darolutamide, it is a damn safe drug. So it has no CNS penetration. So there is very minimal or no side effect related with the CNS, because you see elderly population, generally they have the difficulty in gait. Sometimes they are weak, so they cannot walk by themselves. But this drug is not going to the CNS as contrast to the enzalutamide. So giving in this such population is safer. So there is very minimal risk of fracture and fall with particular this drug. So whenever we find like patient's PS is not very satisfactory, or it is PS2 or sometimes it is more, so we can try this drug. Though it is available commercially in the Indian market nowadays, but it is outside the trial, it is very costly drug. It is around 3,50,000. But still, whenever this drug will be available in the cheaper, you can say the rate, we can use this drug, or maybe in the impanel patient we can try this drug. So Erasmus trial has just opened the gates for the better survival outcome. You see, like we started with the ADT. Then in 2015 we have combined with the ADT plus docetaxel, and 17 we combined with the ADT plus abiraterone. Then subsequently enzalutamide and apalutamide. Now the era has come to combine 3 together, ADT, DOSI plus the safer alternative of the NHA, newer hormonal agent. So you have presented the very nice study. Though it is looking like it has the recent born child in the era of the medical oncology, but it is a good drug, and the combination is working actually. So now can we start our panel discussion?
Yes, sir.
And my sincere apology to our panelists, because we wanted to start at 7:20, but because of some issue in the connecting with the Dr. Tanmay Mandal, I had to present this keynote trial earlier, and so it was a little bit delay. So we are delayed by around 10 minutes. So first of all, I wish to welcome our panel members, Dr. Lalit Sharma, who is working in Jaipur Manipal Hospital. Our dear colleague, this is Dr. Lalit Sharma. He's a very renowned person here in the Jaipur. I could see Dr. Ankur Punia also. So we met very frequently, and he is our sometimes our examiner for our DNB students, Dr. Ankur Punia. So we call him off and on. He's our dear colleague. So and Dr. Ankit Agrawal from Gitanjali Hospital, Udaipur. So welcome, Dr. Ankit Agrawal. Hi. Hi. And the
So
last
Dr. Devesh will be joining 10 minutes.
Yeah, so I called Dr. Devesh, but I know he's usually late in joining, but he will join, I'm sure. So welcome you, and we'll start the panel discussion. So it is basically what we practice in the our clinics. So nothing other than that. Can you share the slides, Kritika? So how
yes, sure, sir. Give me 1 minute.
Yeah, please. So Jaipur, we know about weather and all that. So I might ask Dr. Ankit, how is the weather there? I guess there is heavy rain in the Udaipur.
Yes, sir. Since 2 days, it has been amazing. Rain
Okay.
and no sunlight. So I think Udaipur people crave.
Actually, we are seeing very beautiful videos shot by the drone about the Fateh Sagar and all that. So it's very. I wish to go there.
Please do visit. Please do visit.
Yeah, it's my Nanial place there. So.
Oh, amazing, nice.
It's very long, man. It's good rain and the good environment is there. So we'll start the panel discussion in the management of the HSPC. Earlier, I wanted to discuss this CRPC, but the problem is HSPC has recent trials update, so we just started that. I wanted to discuss that. So we'll start with the case summary. A 65-year-old male initially presented with the severe back pain. This is the usual normal story. The elderly male comes with, usually in my practice, is more than 70% patient comes with the back pain. So usually two differential comes in our mind, like maybe it is multiple myeloma or it is prostate cancer, and especially when the patient complains of the lower urinary tract symptoms. So the patient was evaluated and diagnosed with adenocarcinoma of the prostate with 2 rib lesions and 1 L3 vertebra mets. So there were 3 bony metastases after undergoing the PSMA PET CT. So we all know, like, it is PSMA PET is generally we are doing, and mostly it is available in various part of the state. And prostate needle biopsy revealed the adenocarcinoma of the prostate with a Gleason score 8, 4 plus 4. PSA was 20 nanogram per ml. So my question to Dr. Lalit Sharma, how would you manage this patient? What is your proceedings, or how you will?
Yes, sir. As it is not mentioned, so I take that the patient does not have any comorbidities, and I believe as it is not mentioned, so I'll take it as if the patient does not have any neurological deficit.
Yeah.
Is it so, sir?
Yes, sir. Yes, sir. Yeah.
So considering these two things, and considering that he has a very severe pain, one option which we can provide this patient with is, I believe, the severe lower back pain would be secondary to the L3 vertebral lesion. So for two reasons, one is if the pain is very severe, the patient can receive palliative RT to that particular vertebra, and two, if there is any impending fracture, then also can be offered palliative RT. As far as systemic therapy is concerned, I would like to subject this patient to HRD analysis upfront if the resources are not a constraint, and then present the patient with both the options. I would rather prefer in this patient because the bone load is not pretty much. So along with
Yeah. Have we lost the connection? Hello, Gitika?
Yes, sir, I'm there.
Yeah. So actually, I guess Dr. Lalit has not completed his sentence.
am I audible?
Yeah, Dr. Lalit. Hello, Dr. Lalit. So I might ask Dr. Ankur. So do you do PSMA pattern every patient of yours?
Yeah, I'll try to do in each and every patient if they can, get it done. PSMA PET is, I think, the best modality to.
Okay. Sometimes do you feel like PSMA PET you diagnosed or over-diagnosed the cases, or there is a lead time bias if you do the PSMA PET?
So that's a, ongoing debate because with PSMA PET, you will definitely pick up more lesions, which you will not pick up by other methods and those things. But the thing is, most of the patients which we get are usually with some symptoms. So they already have a set disease. So for
Yeah.
the patients, it matter for those patients who are, detected incidentally, whether to do PSMA PET for those patients who don't have any symptoms. But for our scenario, I would say it wouldn't make that much of a difference, and PSMA PET will help us to, better delineate patient metastatic or non-metastatic.
So where do you put like bone scan nowadays?
If patient cannot get the PSMA PET scan, then yes, definitely bone scan. If patient cannot get it.
Okay. So suppose PSMA PET, you are suspecting symptoms, according to symptoms, it is a bony mats, and you have done the PSMA PET. So there were only 3 mats in this, 2 in rib and 1 the vertebra. And there are few knots, like 1 or 2 knots in the pelvis. So how does it impact your further proceedings about the starting the treatment? Like suppose 2-3 knots in the pelvis, 1 or 2 knot in the periaortic region.
So for nodes, still PSMA PET has a good sensitivity, I will say.
Yeah.
It doesn't have a good sensitivity to see the response per se, because sometimes difficult how much the patient has responded. But for baseline diagnose, I think we have to. Has a good sensitivity for lymph nodes as well. So for those patients, usually the nodes up to para-aortic, though they go into metastatic, but I think still can consider them in that low risk burden disease and can treat accordingly.
Yeah.
Unless until patient had a florid nodes, big nodes going, up the upper abdomen, just a smaller nodes, few pelvic small nodes, para-aortic nodes, still I think can be considered in the low risk burden.
Yeah. So I'll tell you my real case scenario. So, but sometime means like 1 or 2 months back, I got a patient, and there was we did the PSMA PET. So there was one local enhancement in the prostate, and one was lesion in the lung, posterior part of the left lower lobe. So it was like how to decide about. So we had to do the biopsy of the lung lesion. Right. So it was very avidly enhanced lesion, PSMA avid lesion, but we did the biopsy and it was available. It was present in the CT scan also, CT plus PSMA. So we did a biopsy there because we needed to decide about it is a local disease or it is a metastatic disease. So we did a biopsy, core-needle biopsy, CT guided, and it came out to be the negative, means like fibroblastic thing was there. But I don't know how it got the PSMA uptake, but sometimes it happens. So in the low burden disease, if one or two focus are there, we might subject the patient for the biopsy also from the metastatic side, so that we can decide like it is metastatic or not. So that patient was negative. and we gave the local treatment, CTRT, sorry, what do you call it, EBRT and hormone therapy. So that might case you may get in the clinics. And now I want to ask Dr. Ankita Agrawal. Definitely, the patient has a low burden of disease, so you want to give ADT as a first line, or how you will choose about the ADT, or maybe the removing the testosterone from the patient's serum.
Okay. So considering so surgical castration versus medical castration, I think I leave it to the patient's choice whether what is the how frequently he can come for follow-up. So if the patient's compliance feels good, I generally prefer a medical castration. But if I feel that the patient's compliance might not be good, then it is better to go for a surgical castration. That is how I decide. It's basically, I think, the only thing, if the patient is fit, I think it's his choice whether he wants to go for a medical or a surgical castration. Hello, am I audible?
Yes, Ankit sir, your voice is audible.
Okay, so
Asim sir, are you there?
I think we lost contact with Asim sir.
Yes, I think. I think some network issue.
Gitika, can you ask Asim sir, just call him and ask him to rejoin?
Yes, sir, I'm calling with him.
Yeah.
He will be joining in 1 or 2 minutes, sir.
Okay. I think we can have our own discussion, Ankur Bhai and Lalit sir. So what do you feel is severe back pain? Do you generally go for a GnRH antagonist, sir? How do you go about it if the patient is affordable and all that? Very severe back pain, we have a tendency that we push ourselves for GnRH antagonist, I think, so that we have a faster onset of action.
I think the patient, unless have a good amount of burden of disease, I don't think it would make much of a difference whether we use an antagonist or agonist. Patient with 2 lesions, and if you use properly bicalutamide initially, most of the symptoms are controlled. I don't remember recently and seen a flare up of symptoms in any patient. Sometimes we forget, I think, to use initial bicalutamide. That's why they might have, but generally not for a patient with such a low burden. Maybe yes, for a patient with multiple bony disease, so many symptoms, yes, initially for a period, antagonist, and then can switch.
So I would also agree, and my choice here would be rather whether to choose the surgical castration or medical castration, because this patient is 65-year-old, no comorbidities, very low disease burden, and not a very high PSA level also. So I believe this is a patient who's going to probably do well in future. Let's hope for that, and probably going to get ADT for long. So if feasible and if the patient agrees, and if we can go for the surgical castration, probably that will make his quality of life far better.
Exactly. If there are multiple number of visits can be prevented.
Yeah.
Exactly.
So, other than the disease burden, just want to know your views on any other factors you do consider while choosing your ADTs.
I think cardiac history is an important aspect that we have now recently we have started looking for that. Now that the data has come that agonists can have in long term they can have some cardiovascular side effects. So I think that is one thing that I look for. Anything else, Ankur bhai?
No, I think the major concern is the cardiac toxicity only. Otherwise, patient usually tolerates well, irrespective of any other thing.
So have you experienced any cardiac toxicity in my experience? I personally have not. I have just heard that it can cause, and it has just been. We have been explaining to the patient. I have personally not seen such a severe cardiac toxicity or a cardiac toxicity in my experience. So it is just heard and say nothing, no personal experience as of.
I have seen recently, some few months back only, a
Uh-huh.
patient around 70-year-old started on ADT and abiraterone. After 8 or 9 months, his ejection fraction went up to 20%.
Oh my God,
So
that's bad.
I continued abiraterone and I stopped for 3 months completely. Uh, he was pretty much asymptomatic. Ejection fraction improved. It came back up to 40-50%.
Okay,
Patient was not
okay.
that much symptomatic. I again reintroduced, explained them the risk because just abiraterone and it doesn't make much of a sense to me just giving that. I again reintroduced and after that patient is doing well for last 6 months. That ejection fraction has maintained around 40-50%. No symptoms of any heart failure. So
So
though
regularly
So another
monitoring the
thing.
equals.
So another thing
Yes.
which usually perplexes me is how most of these patients are elderly patients, and probably some of them will have comorbidities also. So, is there any particular way we can ascertain that whether it was secondary to the drug or what it was just meant to be because they were elderly and they were already kind of predisposed?
just maybe doing a baseline
I
workup for all the patients.
I think
Otherwise,
But
that is the
here
only
probably
way.
stopping the drug and the ejection fraction improving. Again, another school of thought could be that any cardiac event subsequently the ejection fraction might improve, but then probably withdrawing their drug, ejection fraction improving. Probably that is one way we can kind of.
because I tell you, for this patient, we did a cardiac angio as well because patient had a sudden drop.
Okay.
We initially thought it might be some cardiac event, and that
Hmm.
angio came clean.
Okay.
So,
So
so
then
I had to
again,
stop the drug.
probably the
Nothing
drug
can
And I
be
was
think, I
done.
think,
later.
and I think the temporal association, stopping the drug and then the ejection fraction improving itself says that probably it was because of the ADT.
So when
So you restarted
reintroduced,
the, sorry,
same drug
yes,
or
yes.
that's the same question I was
Uh,
about to ask.
Initially, patient was on Degarelix. This patient was on
Excuse me, sir.
Degarelix. I reintroduced Degarelix only, and
Mm-hmm.
patient is now doing well.
Excuse me, everyone.
Yeah.
My apologies that Seem sir has some issue in joining. So he will be joining again. Till then, can we have a talk by Dr. Neha? And we'll continue the panel discussion, sir.
I think
Yeah.
we have already had a decent panel
Yeah, I think we've
discussion.
already
Okay.
Many aspects have already been discussed, and we have some prior engagements also. The discussion was
Okay.
kind of
So,
delayed also
so we,
initially. So,
so
if with the permission of other
kindly,
panelists, I think we can conclude the discussion.
no problem, no problem, sir, no problem, absolutely.
okay. Okay, so can I call upon Dr. Neha for her presentation? Ma'am,
Yes.
are you there?
Can you upload my presentation?
Sure. Gitika, can we share ma'am's slide?
Hello, good evening, everyone. Thank you, organizers, for giving me this opportunity to speak on this topic. I'll be speaking on the topic GnRH agonist versus antagonist. Next slide. As we all know that prostate cancer is the second most common cancer in males after lung cancer, and it's the fifth most common cancer worldwide, and fifth most common cancer cause of death in males. Next slide. As we all know that these cases are increasing in the developed countries because of increased screening, diagnosis, and healthcare resources. But mortality peaks are seen less in developed countries because of increased screening. Next slide. This is the chart which is showing the prostate cancer data in India. It has been shown that it is 16th ranking in cancer in India and 16th in the mortality list. Why is it so? Is it due to underdiagnosis or something else? Next slide. Next. Finally, what is the reason of prostate cancer? As we all know that prostate cancer because of secretion of testosterone, which is due to the GnRH factor, which causes stimulation of pituitary gland, which causes release of gonadotropin like LH and FSH. LH causes release of act on the Leydig cell of testes and promotes the secretion of testosterone, which releases this testosterone and cause increased growth of the prostate gland and increased cancer in the prostate cells. Next slide. So we know that the main agent where the prostate cancer is happening is the GnRH receptor, from where there is secretion of the testosterone production starts. So we'll be discussing whether agonist or antagonist, what should be used and why it is to be used. Next. As a trial was happened, which was phase 3 trial, the CS21 trial, in which they have taken the patients, they've enrolled the patients in 2 arms, degarelix versus leuprolide. In degarelix, they have given the maintenance dose of 240 mg, and then loading dose of 240 mg, and then maintenance dose of 80 mg versus 160 mg. And the second arm was leuprolide 7.5 mg every monthly. Next slide. Next slide. Yes, as we can see in the graph that there was rapid testosterone reduction with degarelix, whether 240, whether 80 or 160 mg. But we can see that when we give leuprolide at the first start, there's increase in the testosterone. That is, there is a flare in the testosterone level, and then slowly decrease. By day 3, we can see that testosterone, the levels of testosterone are decreased in the degarelix arm, whereas it has increased in the leuprolide arm. So we can see that 96% of patients degarelix arm achieve median testosterone level less than 0.5 nanogram per ml by day 3 versus 0% with leuprolide. And there was no testosterone surge was seen in degarelix treated patients. 65% increase in testosterone was seen from baseline in leuprolide patients. Next slide. Now we can see that with the effect of degarelix, we can maintain the testosterone levels to less than 0.5 nanogram per ml for at least for 1 year. It is as effective as leuprolide for 1 year. Leuprolide in the beginning, it causes the testosterone flare, but afterwards it maintains the testosterone level reduction till 1 year. So we can see from this slide that leuprolide and degarelix are effective and maintain testosterone level below the 0.5 nanogram per ml from day 28 to end of the year. So we can achieve 97% reduction with degarelix and 96.4% reduction with leuprolide, which are almost equivalent. Next slide. Then after this, we can see that when we give GnRH antagonist, that of degarelix, there is sustained and rapid reduction in FSH and LH levels. We can see that leuprolide induced increase in median LH and FSH level at the beginning of the treatment, as we can see, due to which there is increase in the testosterone level at the beginning of treatment. Median LH and FSH level were decreased rapidly and maintained with degarelix over 1 year. So with the reduction in FSH at the end of the year, 89% reduction was seen with degarelix versus 54.8% reduction with leuprolide as compared to the baseline at the end of the 1 year. Next slide. So we can also see that there is significant PSA reduction with degarelix as compared to leuprolide, which is significant value. Statistically significant PSA reduction in degarelix arm as compared to the leuprolide at day 14 and day 28. As seen in the graph, that leuprolide value are in that PSA reduction is not that fast as compared to degarelix arm. Next slide. Next slide. Then we can see the PSA failure. There was similar level of PSA failure which was seen in degarelix versus leuprolide during 1 year of treatment. Almost 16 patients had failed in degarelix arm versus 26 patients in leuprolide arm. And this probability of PSA failure was also 8.9% lesser in degarelix as compared to leuprolide arm. Next slide. In this graph, you can see there is PSA recurrence, which was reduced with degarelix compared to leuprolide in advanced disease. We can see the advanced disease in which there was PSA recurrence events occurred more frequently in patient metastatic disease as compared to less advanced disease. As in the metastatic setting, also we can see that degarelix arm has less PSA recurrence study as compared to the leuprolide arm, in which 17 patients have PSA recurrence. So degarelix works better in metastatic settings. Next slide. There was a low risk of PSA recurrence with degarelix compared to leuprolide in high-risk patient, as told in the previous slide, that in metastatic setting or in the high-risk patient, in which PSA level is more than 20, it works much better as compared to leuprolide. The risk of PSA recurrence was significantly lower for patient receiving degarelix in high-risk patient, especially like in metastatic settings, in PSA more than 20, in high glycemic score. So in those patients, we should consider degarelix over leuprolide. Next slide. There we are seeing that increased time to PSA recurrence or death with degarelix versus leuprolide. As you can see in the graph, which is quoted here, that with degarelix, we are able to increase the time to PSA recurrence versus leuprolide. Delayed time to PSA recurrence or death by 7 months with degarelix as compared to leuprolide, with especially with patient who has a PSA at a baseline more than 20 nanogram per ml. Exactly. Next slide. Next slide, please. There were also significantly lower ALP levels and sustained suppression with degarelix as compared to leuprolide arm. You can see in the graph, they've clearly shown that patient with metastatic disease or elevated PSA level, that is more than equal to 50 nanogram per ml at baseline, had greater reduction in ALP level as compared to leuprolide. So degarelix works better in metastatic settings in high-risk patient and in which PSA is more than 20 nanogram per ml. Next slide. Next slide. Now we can see the adverse events which are happening in both degarelix and leuprolide. One adverse event, that is injection site reaction, which was seen more in degarelix as compared to leuprolide arm. Hot flush was also seen more in degarelix arm as compared to leuprolide arm. And the main thing is the symptoms: arthralgia, UTI, fatigue, which was seen less in degarelix as compared to leuprolide arm. So one major side effect of degarelix is subcutaneous degarelix is associated with high rate of injection site reaction as compared to IM leuprolide. But on the other hand, UTI and arthralgia were more common with leuprolide as compared to degarelix. Next slide. Next slide. As we already discussed, this injection site reactions are seen more in degarelix as compared to leuprolide. These were mostly transient, mild to moderate intensity, occurred primarily with the starting dose and led to very few discontinuations. So this can be ignored also because it has not led to so many discontinuations. Next slide. Now come the phase 2 extension trial, which is in which they have done. They have given the 2 arms only, degarelix plus leuprolide arm, but in this they have crossover from leuprolide to degarelix arm in the next study. Next slide. In this, you can see that the patient who are on leuprolide, they were changed to degarelix after some time. Loading dose followed by maintenance dose, 80 versus 160 mg. Next slide. In this, we can see that there was no significant difference which was seen in testosterone level and PSA suppression after 1 year. No difference in T level between degarelix and crossover group after 1 year of treatment. Median PSA level remained same, that was less than 2 nanogram per ml for all groups. Next slide. Next slide. In this graph, you can see that there was improved PSA PFS recurrence, that is improved PSA progression-free survival after crossover from leuprolide to degarelix. In the orange color, we can see that is the crossover picture from leuprolide to degarelix. We can see almost it is comparable with degarelix, that we have significantly improved PSA progression-free survival as compared to leuprolide. Next slide. There was significant improvement seen in PSA PFS after switching from leuprolide to degarelix, especially for patients with PSA more than 20 nanogram per ml. Next slide. Now come the FSH level, which were decreased after crossing from leuprolide to degarelix. And we can see in this that when we switch over from leuprolide to degarelix, it was almost the same as achieved with degarelix. FSH levels were decreased significantly with switching over from leuprolide to degarelix. Next slide. Next slide. As we all know that we want FSH to be low, because FSH only is the thing which will stimulate the prostate growth, and we don't want high FSH levels in the patients. Now, this is another study which was there, which is comparing degarelix versus goserelin plus baclotamide in reducing IPSS. IPSS is International Prostate Symptom Score. As we can see in this graph, that degarelix is more effective in reducing the symptom score as compared to goserelin plus baclotamide. There was significant reduction seen in both treatment groups, but therefore we can say that degarelix is found to be non-inferior to both the combination. So degarelix can be considered alone in reducing the symptom score. Next slide. As we can see in this slide that we have seen some change from baseline to week 12. We have seen prostate volume reduction. In this we have done the ultrasound first, that is rectal ultrasound, in which we have measured the prostate volume at the starting and at the end of the study, which where we have seen that by giving degarelix, there was 42% reduction in the prostate volume as compared to 25% reduction in goserelin plus baclotamide, which was significant. And then come the serum testosterone level, which were almost the same, and PSA level, which were almost the same at the week 12 in both the arms. Next slide. Here, this is a graph which is showing the changes from the baseline individual IPSS item at week 12. As you can see in all the graphs, below are the symptoms, that are incomplete emptying, frequency, intermittency, urgency, weak stream, straining, nocturia, and quality of life, which was far more better with degarelix as compared to the combination. You can see in the graph, the blue, sky blue is showing the worst scenario, and we can see clearly that in goserelin plus baclotamide, there is more worse percentage of the patients as compared to degarelix arm. This means that there is less symptom score. There was more improvement in symptom, which is seen in degarelix arm as compared to goserelin plus baclotamide arm. Next slide. We can see that degarelix significantly improved quality of life as compared to goserelin plus baclotamide at 12 weeks. Next slide. Now, this is a study in which they have given degarelix as new adjuvant therapy. In this, they have seen that they have taken patient with intermediate or high-risk patients, in which again they have compared degarelix versus goserelin plus baclotamide. Our primary endpoint was the same, mean percentage plus prostate volume reduction from baseline till week 12, and secondary endpoint were symptom score at week 4, 8, and 12, change in serum testosterone level and PSA level at week 4, 8, and 12, quality of life at week 12, and adverse effects frequency and severity of assessments. Next slide. In this, we can see that it is almost the same. Change in the total prostate volume from baseline at week 12 was same in both the arms. In degarelix also, there was 36% reduction in the prostate volume versus 35.3% reduction in goserelin plus baclotamide arm. So it was almost same. So we can quote that degarelix is non-inferior to goserelin plus baclotamide in reducing total prostate volume after 12 weeks. Next slide. Now come this IPSS score, which we can see clearly from this graph that mean IPSS score is far more better with digorilix as compared to goserelin plus biclotamide arm. It was significantly reduced with digorilix. Then we can see the next graph at week 12. We can see that meaningful IPSS reduction was seen with digorilix as compared to goserelin and biclotamide arm. We can see in this graph that -3 means the patient was more improvement in symptom in digorilix arm as compared to goserelin and biclotamide arm. In a patient with moderate lower urinary tract symptom plus IPSS score more than 13, it was seen significantly improved with digorilix arm. Next slide. In this, you can see the reduction of serum testosterone and serum PSA level. It was almost the similar between the two arms, between digorilix and goserelin arm. We can see that at 4th week, these both almost coincided with each other. They were showing the same results. And week 4, week 8, and week 12 are similar between both the arms in both reduction of serum PSA and serum testosterone. Next slide. Now from the CS31 study, in which they have seen the same thing, reduction in the total prostate volume at week 12 and other secondary endpoints. Next slide. In this, we have seen that there is almost similar reduction in the prostate volume in both the arms, like we have discussed earlier. Also, 36% with digorilix versus 35.3% with both the with cosa plus biclotamide. So we can quote here that digorilix is non-inferior to standard treatment therapy and reducing total prostate volume over 12 weeks. Next slide. Here we can see that there was significant improvement in IPSS score in patient with LUTS. We can see that mean absolute change in IPSS score was seen more in digorilix as compared to the cosa plus biclotamide arm. Here also we can see a percentage of patients with IPSS response. We can see 40% of around 38 to 40% of the patients were symptomatically better in digorilix arm as compared to 26 to 28% patient in goserelin plus biclotamide arm at week 4. When we see at week 12, we can see that around 60% of the patients were symptom-free with the digorilix as compared to 40 to 45% patients with goserelin plus biclotamide arm. So we can conclude that digorilix treatment is associated with significantly better IPSS change versus gosa plus biclotamide patient with moderate LUTS. Median PSA reduction was almost similar. Median testosterone reduction was also almost similar between both the arms. In patients with baseline IPSS score more than equal to 13, mean response was significantly better in digorilix arm as compared to the leuprolide arm. Next slide. Now there are disease control outcomes of digorilix versus GnRH agonist. As all the studies we have seen, they are quoting that digorilix is better in controlling PSA reduction, in testosterone reduction, and especially in controlling the symptoms. That is, in the prostate symptom score is definitely better with digorilix arm as compared to the GnRH agonist. Next slide. As you can see in this graph, that PSA progression-free survival was significantly better with digorilix, as digorilix is having higher probability of PSA progression-free survival as compared to GnRH agonist. Next slide. Similarly, we can see that there was probability of overall survival, which was slightly better with digorilix as compared to GnRH agonist. So we can see that very few patients died of prostate cancer over the year of the study. Most men with prostate cancer die of other causes, like the CVD or some other causes, not because of prostate cancer. Next slide. Then we have already seen that adverse events were almost same in both the study groups. Hot flush for the most common adverse effect. And we have studied that digorilix injection site reaction were more in digorilix as compared to leuprolide arm. And most patients reported urinary tract symptoms and back pain with leuprolide as compared to digorilix arm. Next slide. Next slide. Next slide, please. Then come the digorilix. Yes, this is the most important thing because musculoskeletal event and joint-related events are most seen in leuprolide arm as compared to the digorilix arm. So probability of experiencing the symptoms was significantly reduced with degarelix as compared to leuprolide at 12 months, which was significant, statistically significant. Next slide. We can see that degarelix is better than leuprolide because degarelix caused decrease in urinary symptoms plus renal-related adverse events as compared to leuprolide. The probability of renal plus urinary tract symptoms were decreased with degarelix as compared to leuprolide at 12 months, which was statistically significant. Next slide. Now, in summary, we can summarize that degarelix associated with increased PSA progression-free survival as compared to leuprolide. There was improved OS with degarelix, which was seen, and we can see that adverse events are also similar between both the groups. But there was reduction in musculoskeletal and joint-related symptoms with degarelix as compared to leuprolide arm, and also there was reduced risk of urinary and renal tract symptoms with the degarelix as compared to leuprolide arm. Limitation of the study was there were retrospective analysis. Follow-up was limited to 1 year. So we want more follow-up to conclude from this that degarelix is better than leuprolide in all these symptoms. Next slide. Now coming to severe risk with GRM analogs, as we all know that the patient of prostate cancer come in advanced age, and in the elderly population, the most common health risk is cardiovascular event, which is almost 80 to 85% are suffering from the comorbidity, and only 15 to 20% patients are free from any comorbidities. So we'll be discussing about cardiovascular risk with both of these analogs. Next slide. I've already discussed that 15% have no comorbidities and 85% have at least one comorbidity. And we can see that 30% have a history of cardiovascular disease. So we'll be discussing in detail about the risk of this ADT therapy on cardiovascular disease. Next slide. Indeed, they have just mentioned that various studies have been done in which they have seen that risk of diabetes and CVD in patients with prostate cancer when treated with ADT was increased. And in one of the studies, they have seen that why the risk of severe risk and ADT was there, because we can see that the patient of prostate cancer have high level of SSH, and high SSH causes obesity syndrome, metabolic syndrome, high obesity, hypertension, which cause increased risk of CVD in all these patients. Now, in a study which was conducted in 2014 by Albertson et al., it was showing that there was 56% risk reduction in patients with degarelix as compared to patients on leuprolide. But number of studies are going on still. No conclusion has been made on this particular point that degarelix is better than leuprolide in decreasing the cardiovascular symptoms, because by the end of the study, they have seen there was almost similar results seen in both the studies in comparing degarelix versus leuprolide. Now, a large prospective phase 3 study, which was designed, that is a pronounced study, which was designed to provide an answer to this question. But this trial was terminated prematurely due to insufficient patient recruitment plus lower incidence of CV events in those patients. Next. Now, the same, this is the Albertson study, which was conducted between 2005 and 2012. And they have taken pathologically confirmed prostate cancer with performance score less than 2, ADT naive with minimum life expectancy of 12 months. Exclusion criteria were prolonged QT interval, decreased potassium, or long QT syndrome, or any other cancer diagnosed within 5 years. Men were randomized to receive GnRH agonist versus antagonist for either 3 to 7 months or 12 months. And both the baseline characteristics were well balanced between both the groups. Next slide. In this, we can see that there was almost, with the use of degarelix, there was reduction in the CV events seen, that is 14.7% as compared to 6.5% leuprolide arm. Absolute risk reduction, which was seen during the first year, was 8.2% with degarelix arm. But we have some limitations, like it was uncontrolled bias in severe risk factors, and we don't know whether deaths which were occurring in the patient were due to the CV or due to some other cause. Next slide. Next slide. Now here are the following studies which have been already done to just study the risk of CV safety with GRH analog and antagonist. Next slide.
Ma'am, kindly conclude your talk in 2 to 3 minutes.
Okay, just I'm on the verge to finish this. And this slide, you can see that there was a decreased CV event, which was seen when deganrelix arm as compared to the leuprolide arm. Next slide. Next slide. Next slide. Next slide. Here we can see that there was almost 14.7% reduction of CV events with deganrelix as compared to leuprolide arm. Next slide. Next slide. We already discussed this, that there was this reduction of 8.2% seen during the first year in the deganrelix arm as compared to leuprolide arm. Next slide. This was the study which were conducted, which was just showing that GnRH antagonist therapy was associated with fewer CV events as compared to GnRH agonist, such as angina or MI, among men with metastatic prostate cancer. But none of the trial has investigated CV events as a primary endpoint, and mean follow-up durations were short. So we need more follow-up, and we need to investigate more for cardiovascular risk events in both the arms. Next slide. Next slide. In this we have seen that GnRH antagonists may reduce the risk of CV events while maintaining a similar efficacy profile to GnRH analogs, offering advantage in the treatment of prostate cancer. Next slide. This is one of the next study, which is showing Scottish Cancer Registry, in which they have seen that increased CV risk was seen with agonists and antagonists. In this, they have seen that there was 30% increased risk for GnRH and agonists, 50% increased risk for with deganrelix, and no risk with biclotamide monotherapy. But in this particular study, the number of patients receiving deganrelix were very less. That is, only 2% patient having receiving antagonist, and 52% patient are having agonist. So from this study, we cannot conclude that because of deganrelix there is increased CV risk. Next slide. Next slide. Next slide. I just want to summarize my slides. Please come to the last slide. Yes, now the previous slide. In this way, we can see that a trial with the new GnRH antagonist was conducted, that is relugolix, which has shown a low risk of CV events, which is the oral GnRH antagonist, which is almost better than leuprolide in lowering the risk of CV events. A meta-analysis comparing relugolix and deganrelix has found two agents have comparable CV event rates. Results from pronounced, that is first international study assessing the safety of GnRH agonist versus antagonist, reported no significant difference, which was seen in major adverse cardiovascular event, which was seen in both the treatment groups. Next slide. So in the last, I would like to conclude that prostate cancer is the most prevalent cancer in males. Its rising incidence is likely because of the increased burden on patients, carers, and healthcare systems. A large proportion of patients present comorbidities, which can further complicate the therapeutic approach to manage this patient. There is need to delay prostate cancer progression and subsequent death by providing effective disease control, particularly advanced disease, by using ADT. Among pharmacological ADT, LRH and agonists do not always adequately control testosterone, which can negatively affect patient outcomes. There is a need to identify patients who are most likely to benefit from certain treatment in order to improve clinical outcomes. So at the end, we should conclude that deganrelix should be used as compared to leuprolide in patients with advanced disease like metastatic, high risk, or serum PSA level more than 20. And if the patient is more symptomatic, then we should first offer deganrelix, and then we can switch to leuprolide after symptom-free period. Thank you.
Thank you, Dr. Neha, for your elaborating talk. And now I want to resume the panel discussion which we were having, and because of the disconnect of internet, it was just lost. So can I ask my panelists to rejoin, and with my sincere apology that I had a breakdown in the internet connection. Yeah, Dr. Ankur Punya, I could see her.
Yes.
Yeah, Dr. Ankur. So we were discussing, now we will have like 10 minutes or 15 minutes only. So whenever this kind of patient with the limited meds comes to you with the age of like 65 years, what would you like to offer, Dr. Ankur, as a treatment protocol nowadays?
So for this patient, this has a low volume burden disease. So
Yeah.
the best treatment will be to give a ADT and some kind of hormonal agent. So I'm not convinced about a triplet. And definitely, yes, we can give radiotherapy because it's a local radiotherapy can be considered because of the low volume burden disease.
Yeah, point well taken. Radiotherapy, are you referring this patient regularly to the radiotherapy department?
Yes.
And you are convinced about the local control of the disease in the oligometastatic setting?
Yes, because I've seen one or two patients, though not much experience, but yes, still its data is convincing regarding this.
Yeah, actually, that was the conclusion of the Stampede trial also, where they have given in the low volume disease local radiotherapy and they got the survival advantage also. So this might be one option, and you are not convinced with the triplet regimen, right? Yeah.
Because for low volume burden disease, that abiraterone, the piece one data didn't show much benefit, though the daratumumab trial showed benefit irrespective of the burden of the disease. So we don't have daratumumab, so I don't think benefit of adding abiraterone for this subgroup.
Yes, exactly. They have shown like the triplet works better in the high volume of the disease. So we would like to go with the this one doublet therapy, maybe hormonal agent, or what about chemotherapy?
Again, the same thing. Sometimes, firstly, I think it depends on the patient preference. Sometimes, patients, I give them the option that we can give either docetaxel. The benefit is we have to only give for 6 to 8 cycles depending on the scenario, and we can stop. But abiraterone, we have to sort of continue. So it's first of all the patient's preference. Some patients prefer to take chemotherapy for a shorter duration, but I'll say the most of the patients try to avoid chemotherapy and they will take that just a tablet. So it's no any special favor when I will use chemotherapy. It's more of a patient preference.
Yeah, so Dr. Lalit, what is your view about this treatment, doublet, triplet, or maybe the single agent? Dr. Lalit, are you there?
Yes, sir, I'm there. Triplet, I won't be very keen to give this particular patient for 2, 3 reasons. One is that the volume of the disease is not that much. Second is triplet on the basis of us. I would like the data to still mature more hands-on kind of real world data also to come into play and probably then adopt it in my day-to-day practice, and that too probably yes for a high volume disease, but for a low volume disease probably not yet.
Yeah. So they have yeah, you are right. Actually, what I could gather the information from reading various trials and all that, in prostate cancer, one thing is very good fitting is if the volume is low, you keep your therapy options low. If volume of disease is high, then keep your therapy option multiple, maybe add on, this kind of the thing. So this is a charted trial which established the role of the docetaxel in the metastatic prostate cancer. So you see, like in 1966, Charles Huggins got the Nobel Prize for the ADT, discovering the ADT. He simply did the removal of the testicles, and he got the patient got the very good symptomatic relief in pain and other things. And after that, means like see about like 40, 60, 40 or 50 years, the new paradigm comes of the this one docetaxel cytotoxic chemotherapy, giving the survival advantage in the metastatic prostate cancer. And Stampede trial was there where the various arms were there: ADT plus zoledronic acid, ADT plus docetaxel, ADT zoledronic docetaxel, ADT plus abiraterone, ADT plus RT to the prostate, which Dr. Ankur Punya was discussing. If the volume is low, you can offer the radiotherapy also. Next, please. Gitika, next slide. So this is the conclusion of this charted and Stampede trial. I will minimize because I can't see the screen. Okay, so yeah, go back to the previous slide, Gitika. There was a good difference between these two trial arm, this ADT alone and ADT plus docetaxel. So 57.6 months versus 44 months. So first time the graph were widely separated. And you see in the Stampede trial also, the standard of care plus docetaxel got the good results. Next, please. And yeah, so in the started trial, they have divided the patient high volume and low volume. So in low volume, they couldn't show the difference between the ADT and ADT plus docetaxel. But in the high volume disease, they could show the very good difference between these two trial populations. So you see, it is HR ratio was 0.63 if the patient has a good burden of the heavy burden of the disease. So do you divide, Dr. Ankur, your patients according to the burden of the disease? And what is your criteria? Actually, Chartered had divided like 3 bony mets only to less than 3. 3 or less than 3 is low volume burden disease, and more than 3 is high volume burden disease. So, how do you divide, or how do you practice in clinics according to the burden of the disease?
So I follow there because most of the studies have there taken that standard, only charted standard, and most of the studies define their results also based on this. And it's a simple, method to
Yeah, it is
remember.
simple.
It's simple and easy to do. So I think I follow the same method as done is this study.
And actually, we get the instinct and gut feeling of having the symptoms and looking at the symptoms and looking at the scans. It is high volume disease, low volume disease, and sometimes we get an idea from the pathology report also. So, and Latitude had some different criteria for dividing the low risk and high risk disease. Next, please. Yeah, so Stampede trial, they have divided into high burden and low burden disease. So how would you see the Stampede data in the form of like considering abiraterone, or considering radiotherapy, or considering this one, zoledronic acid? Dr. Lalit?
Well, sir, in the low volume disease, definitely I would not be very much inclined towards cytotoxic therapies. Until unless I have the only concern that in due course, probably the patient might not remain eligible for cytotoxic therapy and the performance score might deteriorate and the option might be lost. Other than that setting, I would kind of refrain myself from using cytotoxic upfront in a low burden disease. As far as the point of deciding how whether disease is low or high burden, I would rather go on a case to case basis. And thankfully, most of the times it's not about 3 or 4 or 5 meds. Either the pet seems to be teeming with bone disease, or it is usually like 2, 3, 4 meds. So in those scenarios, probably the choices are pretty well made already. And as far as going with abiraterone is, the only concern usually in my mind is, and which I also wanted to ask the fellow panelists also, is that when we are using local RT in a low disease setting, so usually do we kind of supplement it with the abiraterone or any other hormonal agent also, or is it that ADT plus local RT followed by ADT only?
So in the Stampede, they have done, they have given ADT followed by this one neoadjuvant ADT, and then RT, then ADT, continue ADT in the low volume setting. Yeah. So, and do you find any role of surgery in the low volume disease? Suppose patient has one sacral met, only one. So how do you find the role of surgery? Local surgery.
If only one sacral met, and if there is kind of no pelvic lymphadenopathy, only localized disease, then probably I would kind of opt for ADT local therapy, and if possible, consult my tumor board, and if possible, an SRT to that particular site, followed by adjuvant ADT, and then probably give a treatment-free period also. But I totally know that this is going to be a far-fetched thought here. But at least in a very oligometastatic setting, I might give it a try. And
actually, Dr. Lalit, there was one phase 2 study from the China, Shanghai, where they have done the surgery in highly selected patient, about 100 patients. So there were some robotic surgery was offered to them, because the surgeon find it difficulty to do surgery after RT. Suppose patient has very limited disease, or maybe the stage 3 disease, So if you give RT, then later on the surgery is difficult. So they thought like first we do the surgery, and if required in future, we will remain the option as an option the RT later on. So they have done this trial, and in the very limited study, they have shown the survival benefit also. So sometimes if robotic surgery is prevailing in the country, we might ask patient to discuss at least for the surgery, and remaining the RT in the later option. And I guess if you see the ADT might work for the metastatic setting also. So this is an option. So there was one question, any role of ADT monotherapy? So it is written like frail patients. So do you find anytime you needed to give only ADT, not giving Abiraterone or
I
docetaxel?
do definitely consider only DT also, and in my initial comment also I mentioned that because the
Yeah.
disease is quite low volume, the patient is not having any other comorbidities, and if especially if we are opting for local radiotherapy also, then probably I would consider giving the patient ADT monotherapy also, and very well put by you also that in frail patients also we can very well consider the monotherapy with ADT also.
Yeah, so sometimes the patient is very elderly, like say about 80 or more than 80 years, has comorbidities. So, and sometimes they are stretcher bound or maybe wheelchair bound, then we might consider ADT alone to give them whatever symptomatic benefit it can give. And sometimes it works very well. And you see within 2 or 3 months, the patient may come walking also. So next, please.
So just to share my experience, though it is anecdotal and we can kind of transcribe into the day-to-day practice. One of my patient in almost similar scenario, the only difference probably is that he didn't have any bone mets, but slightly few pelvic lymph nodes and abdominal lymph nodes also. And he has been on, and he's 70 plus, around 74, 75. So when we started him on therapy, he was somewhere around 72. And for the last 3 years, he has been following just on ADT and thankfully doing good, touch wood.
Yeah, this is the same. We have at least 2-3 patients with each consultant where we were hopeless at the beginning. Like patient came on the stretcher and the relative was saying like he is not in senses and he cannot at least sit up, or he is not in the sense of doing the urine, and bowel and bladder habits are affected. But if you give desperately the ADT, they might come after the second ADT and then they start improving, and then you can think of adding other things. So it is second case, Dr. Ankur. It is a very simple case. 62-year-old male, PSA was 45 nanogram per ml. Bone scan was showing 9 mets in different bones, vertebra and all that. But there were no visceral metastasis. Gleason score was 7 and patient had no comorbidity. So it is looking like high volume disease. So what will be your choice of treatment? Next, please, Ankur. Now
So,
your choices might change as compared to the previous case.
So yes, now because it's now we consider like a high burden, high volume disease. So I would not prefer to give radiotherapy, not like definitive radiotherapy. And now for this patient, I will consider adding chemotherapy, if the patient can take, in addition to ADT and a anti-hormonal agent.
But triplet, you will feel it should be reserved, right?
Yes.
Okay, next, please. Nitika will go on fast. Yeah. So it was a piece one study data, where they have shown the radiographic progression-free survival in the patient who received triplet. And mind you, the all were the subset analysis applied to the de novo patient. So you see the median survival was 4.1 versus it is in years, and 1.6 in the standard of care. The p-value was highly significant, 0.0001. It is 0.001, and the HR ratio was 0.47. So almost like see 53% patient had benefited as compared to the recurrence-free survival, or maybe the death can be avoided. So it was very impressive data. And you see the PEACE trial recruited the patient for 6 years, and that time like almost 2 times the standard of care has changed. But very cleverly they designed the trial to show the benefit. So if the time comes we might also think like we can add the 3 drugs if the comorbidities are less and patient are well fitted to according to the PS. Next, please. Yeah, so this is kind of the summary slide. ADT, we have shown the chartered trial had shown 33 months survival improvement, ADT alone. And the Stampede, it was 35 months. In the Stampede, one arm was the ADT alone. The arm A was that. And if you add docetaxel to the ADT, the survival is 40 months. In the Stampede Peace trial, it was 42. And GETUG trial, it was 44 months, and charted it was 48 months. If you add ADT plus abiraterone, it was 50 months in Latitude. This Karim Fizazi was presented in this trial, and 53 months in the Stampede trial. If you add ADT, docetaxel plus abiraterone, the PS1 trial, it was 61 months. So it was good to think about a patient who had a heavy burden of disease and they are fit. We can add this drug abiraterone to docetaxel and ADT. Yeah, next, please. So this was the Aerosense trial which Dr. Tanmay Mandal has presented today. So darolutamide is added to the ADT and docetaxel, and it is clearly shown the survival benefit. It was, you see the placebo and ADT plus docetaxel, it was median survival was 48.9 months, and the graph was separated from very initial part, and the hazard ratio was 0.67. So it is impressive hazard ratio, and the p-value was highly significant between these two. And you see like darolutamide is kind of very well tolerated drug. It has it never crosses the blood-brain barrier, so there are very less CNS side effect, like patient might not feel fatigue, and there is very low risk of fracture and fall. And you can see like generally patient never have the seizures. So you can add the ADT and docetaxel. Next. Yeah, so this is the dissection further with the disease volume. So in the high volume disease, the difference was very clearly seen. It is same with the Aerosense, same with the Peace, same with the charted trial. If the disease volume is high, you add the modalities and there will be the survival difference. And if low volume disease, survival difference will be very minimal or minuscule. So it is like median survival not reached in the darolutamide plus ADT and docetaxel arm versus the standard of care. It was 42.4 months. So the data is getting mature and we will be having more clarity afterwards. Next, please. So this is like how would you decide about the which kind of the combination we should use. So probably level 1 evidence is for de novo disease, because all the trial like Latitude, Charted, and this one Peace trial, they have included de novo disease, de novo metastatic disease. High risk disease means high risk and high volume. High volume multiple mets or high risk is by the you can see the pathology wise, and Fitman is low PS score, PS 0 or 1. So if that is there, then you can add on, keep on adding the modalities. And if patient has recurrent disease, low volume disease, borderline Fitman, then you can choose your treatment protocols according to this particular situation, where you might actually de-escalate the things because patient is not fit. So sometimes you might give single agent ADT or sometime ADT plus docetaxel. And further, if patient improves or later on, you can choose the single agent like apalutamide or some other drugs. Next, please. So this is the same, you see the Peace 1, Aerosense and Enjamet trial. Enjamet trial, in one particular subset, they have added the docetaxel, enzalutamide and ADT, but that had not shown any benefit of getting this 3 drug combination, but these 2 trials were positive trials. Next. Yeah, so take home message from M1 CSPC is current standard till 2022, de novo high volume disease. We need to add in the fit patient, ADT, docetaxel, abiraterone or darolutamide. Unfit patient, docetaxel, maybe docetaxel or ADT plus minus NST, new hormone therapy. If patient is de novo and low volume disease, then at least ADT plus neurohormone therapy and treatment with the, I guess, radiotherapy. Discuss triplet on a 1-to-1 basis, like young fit patient or bone only meds, you can go for this. Relapse and recurrent disease, you might not choose the triplet. It is ADT plus NST, and very frail elderly patient, ADT alone is the choice. And one more choice is if patient is patient has a very low expectation from the life, means like very sick, and you see the multiple comorbidities, PS4 patient, you might do the watchful waiting also. So I guess this is the last slide, and we will, yeah, thank you. Thank you, Dr. Lalit and Dr. Ankur Punia, for staying with us, and my sincere apology I have given earlier also because there was some internet connection problem, and you stayed for a very long period of time. Thank you very much, and actually your contribution I will remember. So thank you, and thank you.
Sir, there are 2 questions in the chat Q&A section.
Okay, yeah, please.
address
I will be happy to answer that. How long ADT must be given in metastatic HSPC or CRPC? Is there any data for short duration ADT? So ADT should be given if patient has responding to the hormone sensitive disease and not converted to CRPC. Even if in CRPC, if you are not going for the medical surgical castration, you need to continue the same. What is your take, Dr. Lalit?
I would probably, I would agree with this.
Yeah, and some other attendees has thrown the question: 72 years, CA prostate, grade group 5 T3B lesion with external iliac and common iliac node showing PET uptake, no other mets. How to approach this case? T3B lesion. So I guess a patient is fit enough, then we might ask for the robotic surgery, and very well they can go for that. And if patient is not ready or there is some problem with the excess of robotic surgery, we can ask for the ADT followed by the EVRT. Is that clear? That true, Dr. Ankur, in your practice also?
Yeah,
Sir,
agree.
I would
Like a
consider
local
this.
disease.
Please go ahead, Doctor.
So I'll treat like a local disease first only. I'll treat like even if nodes are there, though earlier they were taken like a stage, they are considered stage 4, but still I will give the better option and to go for a local disease, like if possible go for surgery, otherwise a local neoadjuvant ADT followed by RT.
And intermittent versus continuous ADT. So the continuous ADT is nowadays standard. But earlier practice was like if patient is having some progression, mild progression, then they might, usually the uro-oncologists do that. They stop the ADT and restart after 4 to 6 months, and they again get the response. So intermittent ADT was the previous practice, and nowadays we are giving continuous ADT. Right, Dr. Ankur?
Yeah.
So these were the all 3 questions we have answered. And now we might close the session for today. And thank you very much for all participants and our esteemed panelists and our speakers also. And thank you for all the pharma support for this academic event. And thank you for the Horizon team for making this possible and giving continued support to us. And thanks for my colleague in the hospital who are giving me the opportunity to arrange this kind of meetings. Thank you very much. And we'll be having a second meeting tomorrow. So please join. Thank you.
Thank you.
Yeah,
Thank you everyone for joining for a great academic feast. And tomorrow we will join again. Till then, good night, everyone.